Well, for us, the father of study implantology or the basal implantology is Dr. Ede sir. In a polite word, we can say he is the modern father of basal implantology. Okay. I am going to invite now Professor Ede sir, my mentor, my big brother. Sir, please come, and he is going to give you an idea. And lecture is on for the disciplines of static implantology, and then you can interact also, and that's how we are going to conclude the conference. Sir, please.
Very much. Yesterday I mentioned that there are defined methods how to put the implants and where to put the implants, and so I will use this chance to talk about the methods. We get sometimes the criticism that we put the implants in a weird way. They are not parallel, and this looks all very strange. But in the reality, the process of placing every single implant in an arch is well defined, and I recommend that you use exactly these methods when you do the treatment. So don't try to invent too much, especially not in the beginning when you don't have experience. There's always the possibility, of course, to use an alternative location or an alternative anchorage point or target cortical. But for the beginning, I recommend that you strictly follow those rules. There has been a lot of discussion which is a method and how many methods are there. I think these are the most important 7 methods. There are also a list of 12 methods or 14 methods. It depends how you want to categorize this. For example, the palatal engagement, where we put the implant from the palatal side of the alveolar crest into the floor of the nose. Basically, it's a floor of the nose engagement also. So this could be a subdivision, or maybe it shouldn't be even mentioned because it's the same. So you can subdivide this even more. I will show you now the most important method. I think this was mentioned already on this congress. Second cortical engagement in the distal mandible. We have 2 options. We can do this in the lingual side or on the vestibulocortical. This is a typical example. As you know, many patients have this undercut on the lingual side. This undercut is a kind of leftover from the time when the molars have been there. And this target cortical is, as you can see, almost perpendicular to the implant, so it's very easy to insert. It's not so easy to insert implants under a sharp angle into a cortex, but here it's very easy to insert that. As you can see, the head of the implant is then slightly towards the vestibular side, and it needs to be bended in lingual direction. In order not to fracture the cortical lingually to the implant, I recommend that you put the implant a little bit also into distal direction, so that you bend it. When you bend it into the distal direction, and there's a much more bone supporting this. There's much more bone to work against these forces. This is where the undercut is found. You see typical situation of a second molar. The molar is more on the lingual side compared to the body of the mandible. This is what more than 90% of the patients provide. And if you feel this undercut with your finger, then the treatment is easy. Here's a typical example. So the implant is inserted from the middle of the crest, or even you can go a little bit more to the vestibular side, and then the implant will project out of the mandible at this undercut, at this usually horizontal cortical plate, and the only structure that could be injured there is the sublingual gland. Sometimes we have swellings in the floor of the mouth after this procedure. I rather think that this could be due to overheating of the bone, or due to the situation where small particles of bone are dislocated into the soft tissues. They have to be resorbed. In such cases, we ask the patient to take antibiotics. Not sure if it's necessary, but it's also moral help to the patient, and if there should be any infection, and this will of course be covered up, we prescribe Avelox.